ولا لا مش كثير؟
في حالة نشوف.
Okay, perfect. So this is just a basic talk. We're going to talk about a little bit about, you know, epidemiology, clinical presentation, a little bit about how to diagnose it, and then how to treat it. So it's very clinically oriented and nothing too fancy, صراحة. So as you know, multiple sclerosis is a chronic and inflammatory demyelinating, and very important also, it's a neurodegenerative disease of the central nervous system. You know, back in the day, I think 20 years ago, we only thought about it as a demyelinating disease, but now more and more evidence suggests that there is an element of neurodegeneration that occurs with multiple sclerosis. It's very heterogeneous, it's a very multifactorial. The thing that we know for sure, it's immune-mediated disease, right? And it's caused by a complex gene-environment interaction. And the hallmark of multiple sclerosis is the accumulation of these lesions or these plaques, which they are an areas of focal demyelination that happen in the white matter greater than the gray matter of the brain and the spinal cord. And again, I think 20 years ago, the classic teaching is that multiple sclerosis was only a disease of the white matter. This is wrong. And now, you know, in the past, I think a decade or two, we have a lot of evidence that there is a gray matter involvement and there's a cortical involvement in multiple sclerosis. It used to be one of the questions, you know, what does multiple sclerosis? It does not involve the gray matter. That's wrong. That's actually, it's proven that it does involve both the white matter and the gray matter. Why it's so important, multiple sclerosis? Because it affects young people, right? And since it affects young people, it has a huge economic and socioeconomic burden on the population, right? I mean, it usually hits people between age of 20 and 40. So you are in the peak of your, you know, career, getting married, having relationships, and so on, and then it will hit you with the disease onset. So that's why it has, you know, a good burden on it, right? It has a little bit higher prevalence in women compared to men. About 2.3 million people have multiple sclerosis around the world, and it's usually, I'm going to talk about different types of multiple sclerosis. Usually, the relapsing remitting multiple sclerosis, which is 85% of the cases, it has a little bit younger onset, and then the primary progressive, it usually lasts a little bit older, and it's more common in males as well. But remember, relapsing remitting multiple sclerosis can happen in children and even in adolescents as well. So we've seen a lot of patients, you know, where they have their first attack, you know, age of 16 or age of 12 even. So it's not uncommon. We see that it's a little bit atypical, and they have a little bit more aggressive attack at first, but usually they do well as they go older. As you all know, multiple sclerosis is a disease of the Western population, and it's mainly above, you know, خط الاستواء, and then it's a little bit above. So the highest is usually in the United States, it's in Canada, and also in the Scandinavians as well, and as you can see in Europe. Our region has not much, a little bit, you know, less compared to others. And then, as you can see in the sub-Saharan Africa, it's actually, you know, less and less as well. And it's unclear why this, how to explain this dramatic, you know, differences in epidemiology in multiple sclerosis. Definitely there's environmental factors, and definitely there's a genetics factors happening. And then they overlap, and there's this complex, a little bit unknown relationship and how to or why to develop multiple sclerosis. Environmental, there's a lot, as you know, a lot of epidemiological studies have been done on it. And the most well-established risk factor is, they are Epstein-Barr virus infection and infectious mononucleosis in early adulthood or adolescence, tobacco exposure, lack of sunlight, and low vitamin D. So these are the big four that they put you at a higher risk of having multiple sclerosis. Again, one of them is not enough, even if you are, and then also the presence of all of them does not mean that you're going to have multiple sclerosis. they studied almost everything to figure out what's causing it. But the 4 of these, they panned out as the highest risk. Now, the generics, familial MS is very rare. It's even less than 13% of all of the MS phenotypes. They have identified approximately more than 200 generic risk variants for multiple sclerosis. Most of these, they are on chromosome 6, and the biggest one, it's usually on the exams, is the HLA-DRB1 1501. So if you remember this, you put it on the test, you get the question right. This is usually on the boards. And this is the one that's associated with a slightly higher risk of multiple sclerosis. And also other genes, including the polymorphism in the T cell activation and the proliferation, has also been implicated as well in the development of multiple sclerosis as well. Now let's talk about the subtypes. Let's do a little bit more clinical. So as you know, the subtypes, relapsing remitting multiple sclerosis is the most common. So what happens is you get this attack, okay? So it attack, and then you improve, and then you get another attack. And that's a classic, with the relapsing remitting multiple sclerosis. I always say that in neurology, you can diagnose any disease you want by asking 2 questions, which is what's the onset of the symptoms, how fast did the symptom happen? And then the second thing is, what's the progression, and what's the time course from the start point till you see the patient now, right? And, it's actually easy, neurology, if you understand it, it's not super hard. I mean, there's only 4 things or 3 things that gives you a sudden onset of symptoms, like within seconds, which is a stroke, a seizure, a migraine. These are the 3 of them that gives you these 3 things. Like nothing else will give you that fast within few seconds, right? Migraine tends to happen within few minutes usually, like a little bit gradual onset, right? Multiple sclerosis is usually within hours to days, okay? So the onset is a little bit, we call it maybe a little bit, it's an acute, but it's not a sudden onset, right? And it usually peaks within maybe a week, and then they usually improve. So even if you did not treat the patient with multiple sclerosis, majority of them, they will improve if you have relapsing remitting disease. And because that's how the natural course is. So, and if you get this demyelinating, this relapsing remitting course, this is highly suggestive of a CNS demyelination, right? Now, some patients, they start with, or actually most of the patients, they start with relapsing remitting multiple sclerosis, and they end up with secondary progressive multiple sclerosis. And the phase of the secondary progressive multiple sclerosis, it happens because we have an accumulation of the multiple plaques. Okay, so you had an attack this year, an attack the next year, and so on. And you keep having more and more disability and more injury to the brain. And as we said, there is an element of neurodegeneration. And that's why you will have a conversion to a secondary progressive multiple sclerosis. Now, about 10% of patients, they start on with a primary progressive course. So they don't have these attacks, which is a little bit unusual, right? I mean, it's very rare, but they start with a gradual progressive. So they just keep getting worse and worse and worse with more and more accumulation of neurological deficits over the year. And then also there's something called primary relapsing multiple sclerosis. So they have a primary course, and then they have also some fluctuation and some attacks going on. I think the first 3, they are the most important, which is, the most important is the relapsing remitting, to understand it. And then some of them, or probably the majority of them, actually, they go into secondary progressive multiple sclerosis later on in the course of the disease. Now we're seeing it less and less, because now we have much more stronger disease modifying therapies. And then we have also, the primary progressive multiple sclerosis, which starts from the onset, and then it's more of a gradual increase uphill of the development of neurological diseases and disability. Now we have something called clinically isolated syndrome, which we're going to talk about. So clinically isolated syndrome is that you have a CNS demyelination. It's the first one, and it does not fit the definition and the diagnostic criteria of multiple sclerosis. which is, it's like a pre-multiple sclerosis type of thing. Most of patients with clinical isolated syndrome, they will end up into multiple sclerosis. Especially, we divide them into high risk and low risk. And if you have a high risk clinical isolated syndrome, then they end up developing into full-blown multiple sclerosis in the future. So this is a nice curve. And okay, so let me explain to you. So this is, we have the relapsing remitting multiple sclerosis. And we think that the relapsing remitting multiple sclerosis, the accumulation of the plaques, they happen in the pre-symptomatic area. So let's assume that the patient's first symptom is here, right? So we already have MRI evidence, and we have, pathological evidence that multiple sclerosis is happening, but we don't have any symptoms, right? And then the patient has the first clinical isolated syndrome. So the first thing, if they fit the diagnostic criteria, then we diagnose them with relapsing remitting multiple sclerosis. And they tend up, they're having fluctuations. So they improve completely, they get another attack, they improve completely, and so on. However, as time goes on, they start to accumulating more and more. And that's why the disability they get, it won't be completely reversible. And then they end up with the secondary progressive course, right? Sometimes, rarely of the patients, they end up with, they start with a primary progressive, with an upgoing slope from the beginning without these fluctuations or attacks. Any questions? Okay, as we mentioned, the pathological hallmark of multiple sclerosis, we have these focal plaques. Focal plaques, they are areas of demyelination, and they happen at around the post-capillary venules, right? And they are characterized by, we have a good deal of a breakdown of the blood-brain barrier. As we mentioned, it happens both in the white matter and the gray matter, and they are found throughout the CNS. So it's a brain, spinal cord, and remember, the optic nerve is also part of the CNS, right? So that's why we get the optic neuritis. It's a very common and frequent manifestation of multiple sclerosis. These, if we have an active demyelinating lesion, they are heavy with, CD8 T cells, CD20 B cells, and a little bit less CD4 T helper cells. We have a lot of activated macrophages, microglia, and also astrocytes as well. Again, another myth that we had is that the CNS is devoid of lymph system, which is a little bit, now it's wrong. Now we know, there is lymphatics or glymphatics as well in the brain. Okay, so let's talk about the clinical presentation. So, okay, we have a patient, as we mentioned, about 85% of patients, they come in with an episode of neurological dysfunction. And this is due to a demyelinating lesion happening in either, the CNS, the optic nerve. So most commonly, it's actually sensory symptoms. So numbness, paresthesias, these are the most common. And then we have optic nerve. So we'll get with optic neuritis, spinal cord with myelitis. You can get also brainstem and cerebellar, which is very common in multiple sclerosis as well, or even cerebral hemisphere, and mimicking like a hemisensory loss or a hemiparesis as well. It's a little bit less common. The attack has to last for 24 hours. As you know, we get a lot of numbness sometimes. Each one of us does it, that lasts for a few minutes or an hour, and everybody gets, oh, is this MS? No. So the attack for an MS, it has to last for a good amount of time. It has to last for 24 hours at least. And in the absence of other things like fever, infection, and clinical features of encephalopathy, and this we'll talk about something called pseudo-exacerbation as well, which is, we'll talk about in a second. But that's the whole point of the absence of fever and infection. So it's usually have an acute or subacute onset. So within, few days is the classic story. And they worsen over a day or two or a week even, and then they decrease and then they improve. And this is actually very common, is that in, sometimes the patients, they don't present with the first attack. If they have a numbness, they just, they keep going. And they don't notice it as much, and if it's not disabling enough. So they come maybe the next year or the following year with a weakness or with a hemiparesis. And then you ask them more, and then you know what? Yeah, last year I had I had an episode of numbness that lasted for maybe 3-4 days, and then it went away. So that's it. So now you have clear evidence of a relapsing remitting course that's happening. So always ask in the history about any previous episodes of transient neurological symptoms that lasted maybe for a couple of days or so, because not everyone will present with their first. It's very common. It's kind of like seizures, right? You know, patients with epilepsy, they usually present whenever they have their big tonic-clonic convulsion, and they don't come with, you know, with the focal unaware or, you know, the auras that they have. But if you go back in history, they would have it for the past several months or years. Any questions? Okay, as we mentioned, sensory symptoms, they are the first clinical manifestation, about 40%, 43%. And it's usually caused by a spinal cord lesion or a brain stem actually lesion, right? So it includes paresthesias, so numbness, tinglings, pins and needles, tightness, coldness. Some people describe something called MS hug. So the MS hug is usually due to a cervical thoracic lesion, where you get, you know, whenever they breathe or something, they will get like this, this pain and the circumferential pain that happens. You all know what's a Lermite sign is. So Lermite sign is, it's an electric shock sensation that goes down from the neck down into the back. And this happens usually when you do neck flexion. Lermite sign is a non-specific sign. It just tells you that we have a cervical problem, like a cervical spine problem. So even in patients with a disc, with a cervical spondylosis, you would get a Lermite sign. But you know, that's the classic, and it's just a mechanical pressure, because when you flex your neck, you will stretch the spinal cord, and that's why you will have this electric shock sensation, right? Now, on a neurological examination, you usually have vibration and joint position sensation decrease. Typically, multiple sclerosis lesions in the spinal cord, they involve the posterior spinal cord rather than the anterior. And that's why the dorsal columns, they are usually affected in multiple sclerosis. So you will get decreased vibration, you will get also impaired proprioception, fairly common in multiple sclerosis. And of course, you know, you would get sometimes reduced pain and light touch if it involves into the spinothalamic tracts. All of these sensory symptoms, they get worse whenever you have increased body temperature. And this is known as the Uthoff's phenomena, right? And it's the same thing with fever as well. If you are sick, you know, you have a flu and so on, you will get recrudescence of all of the symptoms, of all of the previous symptoms, particularly the sensory symptoms. Now, optic neuritis is usually the first neurological episode in about 25% of patients. Over the course of multiple sclerosis, optic neuritis is very common. About I would say, I think 70% or 3/4 of patients with multiple sclerosis, they have optic neuritis throughout their whole course. And this is always, you know, it's a fairly common presentation, which we have, you know, the first episode of optic neuritis, which we call it, you know, idiopathic optic neuritis. And then what's the risk of conversion into multiple sclerosis in the year? And the risk is about 34 to 70%. So it's a very wide margin, right? And it depends if you have anything else, you know, any demyelination in the brain, like a silent demyelination in the brain, depends on other risk factors. If you do CSF analysis, look for oligoclonal bands and immunoglobulin synthesis. Also, it might tip you to the high risk or to the low risk of progression into full-blown multiple sclerosis. So what is optic neuritis? So from the name, it's inflammation of the optic nerve, right? And since we have inflammation, we should have pain. So the hallmark of optic neuritis is pain, right? So it's pain upon what? Upon moving your eyes. So whenever you move your eyes and just you have this intense pain. And the other thing is that you will have decrease in the vision. So you have, and which type of vision? It's usually the peripheral vision. So you can't see the, I'm sorry, it's usually the central vision, I apologize. So you can't see the central, but you can still see a little bit of the peripheral. So that's the classic. The other thing is that you will get this chromatopsia, which is deficiency of the color vision. You stop seeing the colors. So 3 things. So we have pain, very important, central vision loss, and deficiency of color vision as well. So this is the hallmark of optic neuritis. Now, optic neuritis on the fundus exam, you could see normal. Why is that? Because remember, because the myelin sheath in the optic nerve, it ends up actually retrobulbar. So if we start, let me, sorry. Anyways, so what happens is the optic nerve is like, let's suppose that the globe is here, and then here is the optic nerve, right? And usually the myelin sheath, it ends up retrobulbar to it. And that's why most of the inflammation, they will be retrobulbar. So you would see normal. So the classic teaching is that the doctor sees nothing and the patient sees nothing, which is a normal fundus exam. However, you could see papillitis and inflammation about a third of the cases if the inflammation was severe enough and it extending into the actual optic nerve head. Usually in multiple sclerosis, it's a unilateral, so one eye. If you have a bilateral optic neuritis, it's atypical for multiple sclerosis, and you should think of something else, which are neuromyelitis optica and myelin oligodendrocyte glycoprotein, which is MOG antibodies. So in multiple sclerosis, it's usually one eye, unilateral, most of the time. Okay, motor manifestations, they can happen about 30 to 40%. Of course, it's just weakness and paresis. And the classic is the remember, we're talking about an upper motor neuron lesion. So it's all a pyramidal sign. So pyramidal type weakness, which is flexors of the upper extremities, extensors of the lower extremities. You will get Babinski sign. You will get a little bit of hyperreflexia. You can get spasticity later on as well. And then the brainstem and the cerebellar symptoms, you will get ocular movement. So the classic one is what in multiple sclerosis? What's usually the classic presentation for abnormal eye movements? Any ideas? So it's usually internuclear ophthalmoplegia, right? So it's the INO due to the disruption of the medial longitudinal fasciculus, which is the lamella. And the classic is a bilateral INO. If you have a bilateral INO, this is usually multiple sclerosis. Oh, sorry, I can't hear you. Other things, including oscillopsia. Oscillopsia, it's a sensation that the objects are moving, and usually it's a brain stem. And as well as diplopia and maybe abducent nerve palsy, maybe oculomotor nerve palsy, and so on. And then ataxia and dysmetria, and also you could have a lot of other brainstem, speech, dysphagia. It depends where the plaques are. The last thing is that sphincter and sexual dysfunction is also very common in patients with multiple sclerosis, particularly later in the disease, and it goes hand in hand with the motor impairment. Okay, so we're going to talk a little bit about the typical. So again, optic neuritis, the typical is usually unilateral. So if you have a bilateral, it's a red, you gotta think, is this maybe it's not multiple sclerosis, right? So it's usually unilateral. Another thing that happens is afferent pupillary defect. And you know how to do the afferent pupillary defect is by the swinging torch test, right? And you will get central vision blurring or scotomas, reduced visual acuity, and then color blindness, and then you will get this pain as well. So that's the classic is pain. That's the first question usually in the ER. Whenever the ER calls you with a vision loss, unilateral vision loss, right? Is it painful or painless, right? If it was painless, you call ophthalmology. That's not us. If it's painful, then it's us, right? Then we have, look at the atypical. So if you have severe optic disc swelling, retinal hemorrhages or exudates when you do the fundoscopy, if you have peripheral vision loss, this is usually, and no pain, this is usually atypical for optic neuritis with multiple sclerosis. Now, same thing with the brainstem and cerebellar syndromes. You will get, internuclear ophthalmoplegia, nystagmus, sixth nerve palsy, ataxia gait imbalance, vertigo, facial numbness and sensory loss, and dysmetria, dysphagia. Hearing loss is a little bit atypical. You think of something called Susac syndrome if you have a significant hearing loss with a demyelinating picture. With the myelitis, the classic with the myelitis, as we mentioned, you will get a sensory level, right? So you have either a cervical or a thoracic lesion. You will get a sensory level. So pins and needles, numbness, lack of sensation as well, and along with the motor deficits. You could get a Brown Secord sometimes, which is, the hemi, incomplete transverse myelitis, or an asymmetric with a preferential for the motor and the sensory pathways on both sides, of course. And then for the cerebral hemispheres, it's a little bit rare, but it can happen, which is you will get a hemi syndrome. It's either a hemisensory loss or a hemiparesis, mimicking a stroke, of course. But you can tell it's not a stroke from just the presentation, because this is usually over days it happens, and it progresses over days rather than the stroke where it hits you within a few seconds. Okay, so how are we going to diagnose this patient? So the first thing is to say that the patient has a clinical presentation typical of multiple sclerosis, related demyelination. So we have an evidence that we have CNS demyelination from the clinical history. Then the other thing, we need some objective evidence. And this objective evidence, it's either physical exam, it's either MRIs, CSF. So physical evidence that we have CNS demyelination happening. The third thing is that we need the classic thing now, we need to demonstrate dissemination in space, dissemination in time as well. And what we mean by that, dissemination in space, meaning that we have more than one areas of the central nervous system, they are affected. And dissemination in time, that they are affected at two different time points during their lifetime. And of course, no better explanation than multiple sclerosis. Any questions? Okay, so we had the McDonald criteria, and it's used to diagnose multiple sclerosis. Back in the day, it used to have, you only have to have 2 clinical attacks to be diagnosed with multiple sclerosis. But then in 2017, they rechanged it. And so now you can have 1 attack and you can still be diagnosed with multiple sclerosis if you prove that you have dissemination in space and time by other means. So if you have 2 attacks and you have 2 objective evidence that you have 2 systems involved, then you got your diagnosis. You don't do anything, right? The question is, whenever you have the first attack. So the first attack, you need to have to show that you have a dissemination in time demonstrated either by an additional attack if they have, or by an MRI or CSF oligoclonal bands. Because the oligoclonal bands, it means that we have a chronic inflammation that happened before. So that's your dissemination in time. And then your dissemination in space is that you will have with the MRI with multiple lesions, and the one lesion that is not affected by the symptoms. Let me tell you an example. Let's suppose that the patient has a myelitis, okay? So they came with a presentation of myelitis, weakness in the lower legs with sensory loss also in the lower legs, and flaccid paralysis. So we did a cervical spine MRI, and we showed a lesion in C7, C8, okay? And this lesion is enhancing, so it's active lesion. So that's the lesion that's causing the patient's symptom, okay? So that's we have an objective evidence, and also we have a physical exam, so that the patient has a 1 attack and 1 significant evidence. Now, what happens if we looked into into his eyes, and we found that the patient has also a relative afferent pupillary defect. This means that he had a prior history of optic neuritis, right? So now we have another evidence of dissemination in time and space, because now he's not symptomatic, and we still have an objective evidence. So here we have a diagnosis of multiple sclerosis. You're done. Let's suppose that we did a brain MRI on the same patient, and it showed multiple lesions of the brain. So these are completely independent of his cervical lesion, and they're not causing any symptoms. Perhaps they did in the past, perhaps they didn't. It shows you that we have dissemination in space as well. Got it? Okay, let's see MRIs. So the classic finding is a periventricular demyelination. You see it? Periventricular. You can see it juxtacortical as well, and you can see it subcortical as well. So these are the classic three. And look how these are ovoid shaped. So that's also another thing. Ovoid shape. It's like, you know, it's like a cotton ball here. And this is a brainstem. This is a demyelination and the cervical spine. Okay, so this is C2, 3, and 4. And look how it's usually 1 to 2 segments only. This is also another important distinction in multiple sclerosis. At the demyelination multiple sclerosis in the spinal cord is a very short. We call it a short segment demyelination. Contrary to, we call it the longitudinally extensive transverse myelitis, which spans over multiple or more than 3 levels. Again, these are, we call them Dawson's fingers, which I'm going to show you another picture. Again, we have a periventricular demyelination here. Look at the nice ring enhancing. Can you see this? So here, so this is a T1 post contrast, and we have that a ring enhancing lesion indicating that we have an active demyelination happening. So we have an active blood-brain barrier breakdown, and that's why the contrast is enhancing here, or the region is enhancing with the contrast. Typically, the ring enhancing lesion in multiple sclerosis, it's an incomplete. So it doesn't, it's not complete like this, it's like this. So it's a C-shaped. And this differentiated from, for example, cerebral abscesses, glioblastoma multiforme, and you know, these are mainly the 3 things. And this is the oligoclonal bands. So the oligoclonal bands is you compare the serum and you compare the CSF. And we usually have oligoclonal bands, you know, with the chromatography in both of them, the serum and the CSF. But we look for unique, which they are only present in the CSF and they are not present in the serum. And this suggests that we have, you know, a robust CNS intrathecal inflammatory response happening. So again, so this is the flare abnormalities, and here we have actually a restricted diffusion. Restricted diffusion with this picture here suggests that we have an active demyelinating plaque. So we have an active inflammation happening with this patient, and the same thing with the small, with the small faint enhancement as well. These are the Dawson's fingers that, you know, I was mentioning, and they come through the perivenular because it indicates that the inflammation is usually in the perivenular capillaries that happens. Any questions? Diagnosing multiple sclerosis now in the era, you know, of MRI, it's not super hard. Okay, how are we going to treat these patients now? So the treatment, it can be divided into multiple things. The first one is, we call them disease-modifying therapy. So disease-modifying therapy, they are help to reduce the inflammation and to prevent any future clinical attacks. The other thing is how we're going to manage the acute symptoms. So if we have an acute MS attack or relapse, and then symptomatic treatment, of course, for fatigue, pain, spasticity, and then the pseudo-exacerbation. So we talked about a little bit of the pseudo-exacerbation. You treat the underlying cause. You know, if you have fever, you have infection, you have stress, You just treat the underlying cause, and the symptoms, they will go away, right? And then the symptomatic treatment is it's usually for the chronic. If you have pain, you treat the pain. If you have fatigue, if you have spasm and spasticity as well. Now let's talk about the management of MS relapses. So the management of an acute MS relapse, it depends on the severity of the symptoms and depends on how much the patients they come, right? So what's happening is the hallmark, or the cornerstone, is usually steroids, right? So you give them corticosteroids, and if the patient can't walk, can't see, it's a very disabling, you bring them in and you give them intravenous methylprednisolone, and usually we do 1 gram for 3 to 5 days. It depends on the symptoms. Some patients, they do also a taper of prednisone after that, just to decrease the inflammation. However, if the patient is having just sensory symptoms and they don't want to be admitted, you can still treat them with oral prednisone, mega doses, so huge doses of oral prednisone or dexamethasone, and they can be at home without need to be admitted. It's unclear whether the treatment of an acute relapse will affect the natural prognosis or the natural history. It usually does not. It will just make the recovery fast. Sometimes if the lesion was, if the symptom and the disability was very severe, then we usually do either plasmapheresis or intravenous immunoglobulins after the intravenous corticosteroids. Okay, now disease-modifying therapy. Now, disease-modifying therapy, we have probably, I think, 15 now of them. What do you guys have in Nablus? Which ones do you guys use? Okay, so probably, yeah. So you have Copaxone or glatiramer acetate, interferons, of course, right? I can barely hear you guys. Sorry. Do you have any of the orals? That Tecfidera, Gilenya, no?
مافنكليد موجود، تقريباس موجود، انترفيرونز موجود. حسب if it is highly active, we use more efficacious therapy such as Tecfidera, such as Privas.
Oh, okay, great. Okay, perfect. Okay, so yeah, I mean, usually what we divide the disease-modifying therapy into either a first line and a second line. And there's usually two schools that they are usually debated in how to treat multiple sclerosis. The first school of thought is that we do an escalation therapy. And escalation therapy, it means that you start with the first lines, you start with the, with the easy agents. And then through the course, if they fail them, you give them the big guns later on. The other school of thought is that, no, you start with the big gun from the beginning. So you hit hard, you hit fast from the beginning. And this is hopefully to prevent any future attacks, okay? It's unclear which one is better. It's very variable, honestly, depending on the center and depending, who's treating. But anyway, one of the best medication for multiple sclerosis, especially, the early multiple sclerosis, is Copaxone or glatiramer acetate. This is usually a subcutaneous injection, and it's given either every day or every 3 days, every other day. And it's very well tolerated with patients, actually. The only risk, and usually no systemic side effects. What it gives you just local injection sites. So you will get some erythema, inflammation whenever you inject yourself. That's mainly the side effect. It can give you some anxiety and palpitations and chest tightness, but it's very, very minimal. Now, the first one that was used is actually interferons, right? And interferons, they are either IM or subcutaneous. And they have been used, in the 90s for years, right? And then we started having all of these other new medications happening. Interferons, they give you a flu-like. So that's why people, they hate them, because you feel like shit for a couple of days after the injection with the flu-like symptoms. Rarely it can give you some leukopenia, thrombocytopenias, and anemias as well, and some thyroid dysfunction as well. Now, teriflunomide, which is Aubagio, it's an oral pyrimidine inhibitor. So it's one of the oral medications, right? It's very also well tolerated. It can give you a little bit of GI side effects, some hair thinning, some leukopenia and liver damage as well. Now, Tecfidera, or the dimethyl fumarate, it can give you also some liver damage, some also more of GI flushing and GI side effects. Some people, they take aspirin with it, like a low dose baby aspirin. It will prevent these symptoms. And then fingolimod, which is, what is it called? I forgot the trade name, but it's an oral sphingosine 1-phosphate inhibitor. And it's about 54% efficacious. The one thing with the fingolimod is that you need to have a first dose monitoring for the heart. So you bring the patient in, you put them on EKG, and you give them the pill, and you monitor their heart rate for a couple of hours. I think the protocol is for 4 hours, and to make sure that they don't get any bradycardia. This one is gone. Alemtuzumab is a CD52 antibody. It's very rarely used, actually. The big one, it can give you a lot of autoimmune problems. So it can give you ITP, immune thyroiditis, glomerulonephritis as well. And the big two that we use now, and particularly this one. So ocrelizumab is just it's just an anti-CD20 antibody, which is the same exactly as rituximab. It's just 10 times more expensive. And it's very now well tolerated, and it's actually very well used, particularly in advanced cases of multiple sclerosis. Same thing with natalizumab. So as you know, natalizumab is a monoclonal antibody against the VLA4 antibody. And the big thing with natalizumab is progressive multifocal leukoencephalopathy. So it came in, I think, in the late 90s, early 2000s. It was revolutionary. Everyone loved it. It was great. And then they discovered that it causes PML, or progressive multifocal leukoencephalopathy. So it was withdrawn from the market for a couple of years. And then the FDA, they made the company to have a database now. And then they reintroduced it. And this database, so now every patient getting natalizumab is registered, and it's followed up very closely for it. And usually the PML risk is only with prolonged exposure, so more than 2 years, and if you have a JC virus antibody positive and so on. But it's a very good medicine. Although the PML is a little bit, scary for patients. Any questions on the treatments? No? Okay. I just want to talk a little bit about differential diagnosis of multiple sclerosis. There's a big list of differential diagnoses of multiple sclerosis, but I think the most important thing is to look for the CNS demyelinating that looks like multiple sclerosis. And the biggest ones, they are neuromyelitis optica, which is NMO antibodies. And the second one that we're seeing more and more is MOG, myelin oligodendrocyte glycoprotein encephalomyelitis, right? Clippers as well can look like it. ADEM, particularly in pediatric patients. We have also lupus, Behçet's, sarcoidosis, Sjogren's as well, very rarely, but it can. Genetics, you look for Fabry's, Leber's hereditary optic neuropathy, particularly, in patients with visual symptoms as well. And I just want to show these couple of slides, which gives you a little bit of red flags, like when to think that, oh, this is not multiple sclerosis, there's something else going on. If you have any bone lesions, you want to think of that, is this histiocytosis actually? Lung involvement, so you have a lot of prominent lung involvement, so think of sarcoid. Multiple cranial neuropathies, you think of sarcoidosis, you think of tuberculosis as well, because they love the basal, they give you basilar meningitis, which, a lot of cranial nerves. If you have peripheral neuropathy, it's usually very rarely, because remember, multiple sclerosis is a CNS demyelination rather than a peripheral demyelination. So you think of, adrenoleukodystrophy, metachromatic leukodystrophy, vitamin B12, right? If you have central venous sinus thrombosis, think of Behçet's syndrome. So Behçet's, it's actually more common, in the Middle East than in the US. If you have, think of vasculitis, maybe antiphospholipid antibody syndrome. If you have a lot of vasculitis with some venous sinus thrombosis, stroke-like symptoms with it. Extrapyramidal features, think of Whipple disease, Wilson disease as well. For example, let's see, diabetes insipidus and significant hypothalamic involvement. You think of sarcoidosis, you think of also histiocytosis and the neuromyelitis optica disorder, which is the aquaporin 4 antibodies. Mucosal ulcers, think of Behçet's disease. Maybe lupus as well, it can give you mucosal ulcers, right? And then these are mainly, I think you can guys read these, but I thought it might be helpful. I just want to talk lastly about two diseases, which I think they are important and they're getting more and more attention in the last maybe decade or so. So we have two big diseases that they are now with the demyelination. So we have multiple sclerosis, and the second one is neuromyelitis optica, and the third one is MOG antibodies. And neuromyelitis optica has been, I think for the past 200 years we know them, right? It used to be called the Devix disease. But more lately, in the early 2000s, we discovered the antibody that's causing it, which is the aquaporin 4 antibody. And this has been, revolutionized actually, and in the management, in the understanding of the disease, and so on. Neuromyelitis optica, the classic feature is that you have a transverse myelitis that is long. So we call it longitudinally extensive transverse myelitis. So it has to span more than 3 vertebral segments, right? So this is very, very, characteristic. The other thing is that you should have optica. So the neuromyelitis, that's one, and then you will get the optica, which is usually bilateral, severe optic neuritis. It can happen unilateral, but it's usually severe inflammation, the first attack of it. And then the third one is that you will get intractable nausea, vomiting, and hiccups from area postrema. This is a classic. I remember I had several patients. They come to the ER with intractable nausea, vomiting, and hiccups, and they have been to GI, to medicine. They got EGDs and scoped and so on. And then finally they come and they see us, and we diagnose them with neuromyelitis optica because they have this area postrema at the floor of the fourth ventricle. They would have this active demyelination that's causing their symptoms. So these are the three diseases. So we have multiple sclerosis, we have aquaporin 4, which is the neuromyelitis optica, and we have the MOG IgG antibody, right? And there's a little bit of significant differences between them, actually. The neuromyelitis optica, it's much more common in females. It's 9-to-1. Overall, it's much rarer, both of them, than the multiple sclerosis. And the typical course is that the neuromyelitis optica, although the first attack is very severe, but usually you don't get this multiple relapsing remitting. It's just like it hits you, and then you do have you end up with some disability from it, but usually you don't get that severe or that frequent attacks comparing to multiple sclerosis. The antibody is the key. I mean, you just have to test for the antibody when you have the suspicion, and it will be positive. The brain MRI, it can be normal in NMR because remember, it's neuromyelitis, so and it's optica, so it's usually the eyes, the spinal cord, and maybe the brain stem. It will give you that. And the acute treatment, they are all the same approximately. You'll get IV steroids, plasmapheresis, and perhaps IVIG. Now the maintenance is different, and that's the key in the differentiation. If you give a patient with neuromyelitis optica one of the multiple sclerosis disease-modifying therapy, they will do worse. So remember that. So if you have a patient in clinic who you're giving them Copaxone or Tecfidera or whatever, and they are still having more attacks and they're doing worse and worse, say, you know what, let's take a second. Is this multiple sclerosis, or is this aquaporin 4 or NMO? Because this is a classic, or this is a classic, and very important distinction is that the treatment of the MOG and of the aquaporin 4 is actually exacerbated by the multiple sclerosis medications. So we tend to use more broad spectrum, azathioprine, rituximab, Cellcept, or mycophenolate amofetal, methotrexate, rather than the disease-modifying therapy used for multiple sclerosis. And these two are very good resources for for reviews for just basics, multiple sclerosis, and pathogenesis, and the clinical presentation and the differential diagnosis. And I think that's it for me. What questions do you guys have? Do you have any questions? No? Okay. Do you guys, what other topics would you guys like to discuss in the future?
Hello, doctor. It's me, Zaid Najdawi.
Hey, Zaid.
I have a question. I did not join the lecture from the beginning. I don't know if you talked about it, but how strong is the association between EBV infection and the development of MS in the future?
Yeah, it's a very good question. It's not very strongly. It's it's all based on odds ratio. So it's approximately, maybe I think it's three times higher odds of developing, but it's not a solid relation. Yeah, association. Exactly. And I mean, that's the problem with all of these epidemiology, is that you're going backwards in time, right? And now you're just trying to predict the future, but it's just a risk factor, but it doesn't make anything.
Okay, thank you so much.
Yeah. Well, let's see, we have a question in the chat. Median life expectancy for patients with MS. Yeah, that's a very good question, actually. And more recently, the median life expectancy has been comparable to without multiple sclerosis, particularly if you control the disease early on. If you start a disease-modifying therapy and you follow up with an aggressive treatment, I mean, a lot of patients, they are just living their life without any problems. I mean, we have physicians, there's the CEOs, you name it, right? So it's improving significantly with the advent of these disease-modifying therapy. One thing I did not mention is that there is some more recent research that looked at bone marrow transplant for multiple sclerosis, and there was a study last year from Canada, I think, that the patients got cured for 7 years so far after a bone marrow transplant for multiple sclerosis. So it's It's also remarkable. And some centers, they're doing that now, and they're studying it more and more. Okay. Hey guys, thanks for listening. وإن شاء الله بنشوفكم next time. Let us know, let Rami and me know if, you know, what topics in urology do you want me to discuss, and I'll be happy to do it.
بيحكوا إن باركنسون disease.
Oh, Parkinson disease. Okay, sure, we can do that. Just like a clinic management.
Yes.
Diagnosis and clinical management.
Okay, sounds good. Yeah, we can do that. Okay, guys, have a good one.
شكرا.
Thank you so much.
Thanks, Doc.
يعطيكم العافية. Bye bye.